So let's start. Yeah, this is yours.
Thank you very much. Thank you for being here. Thank you also for the people who are online. I'm defending my PhD today called Transforming Healthcare Practices, Integrating Praxeological and Socio-Technical Perspectives on Social Change. I have a rather conservative agenda. We'll start with the background, the research problem, methodological approach, empirical results, where I present briefly my 3 papers, and then I come to conclusions and contributions. The background. We have a huge challenge when it comes to healthcare systems. They are structurally designed for acute curative services, and they are not well suited for long-term specialist services that chronic diseases and non-communicable diseases require. But we're in a situation where we have a demographic change. 1 in 5 Europeans is above 65. This number will rise. 90% of the deaths by now are chronic diseases. So this is becoming more and more a challenge. And at the same time, the healthcare system is under enormous fiscal pressures, but also under pressures from workforce. There are not enough doctors and especially not enough nurses and care providers. So innovation is seen as a solution to this wicked problem. But there's a massive implementation gap. 1 in 7 evidence-based innovations is actually adopted in practice. And on average, it takes 17 years until these results really are taken up. But this is a huge challenge to improve the situation, to accelerate the taking up of innovations. So this is also my research problem. Promising services fail to change practice, even though they are needed to transform the system in the face of this, I call it the wicked challenge. This is where my PhD comes in with the core objective to develop a framework and test this framework that connect the things people do while providing healthcare practices to dynamics of system change. This is operationalized in 3 research questions. How is feasibility of emerging healthcare services achieved? How is legitimacy of transformative innovation established within the healthcare field? And how do actors create opportunities for transformative change within the field? I build on 3 theoretical pillars: social practice theory, socio-technical transitions theory, and institutional theory. Practice theory has the advantage that it captures this micro texture of routines and the socio-material activities in the daily routines of people. But it really struggles to explain macro-scale change and this power and system analysis. Socio-technical systems theory provides a very good framework for capturing long-term systemic changes, but at the same time, it's often deterministic, structure-focused, abstract, and black boxes practices and doesn't capture agency well. Institutional theory explains legitimacy norms and regulatory process very well, but also neglects often the material technological side and also tends to be deterministic. So I use these theories in a combined way, and I'm contributing to an emerging literature on crossover frameworks between social practice theory and socio-technical theory. But these frameworks are rather immature so far. They don't capture all the things that both theories can actually deliver. Things like landscape, for example, is lost regularly in this integration. And where my framework is different is that I build on the institutional reading of socio-technical theory, building on Schilling, and on Schatzky and on his attempts to integrate institutional theory and practice theory. Thus, I use institutional theory to build a bridge between practice theory and socio-technical theory. I have some key concepts thus. I see the healthcare system as an organizational field, which falling into Schilling can be seen as a special case of a regime. It contains all the relational space that contains all actors and technologies that are mobilized in practices. I'm aware that multiple logics coexist in this field. It's not coherent. They might be conflicting. They might create tensions that hinder or enable innovation. And everything normally contributes to stability in these systems. These systems are made for stability. And the unit of analysis actually is the single healthcare practice following a social practice theory approach that I defined as a cluster, as a connection of different activities, understandings, materialities. The activities are the routinized bodily mental actions of the practitioners, what they actually do and say while they provide services. The understandings and the meanings and norms and logics that are inherent to the practitioners that shape their actions, and the materiality, the physical artifacts that they throw upon while implementing. That might be pharmaceuticals, medical devices, hospitals, can be specific to healthcare, not necessarily have to be. And I understand the transformation as a process of reconfiguration. Those new elements are put up in these practice bundles. So the actions and the materiality bundle together in practice bundles. Thus, the reconfiguration is the implementation of new elements, creating of new links, breaking new links, getting rid of elements. And this is a continuous process that I say is an institutionalization process from something that is outside of the field. It gets picked up, gets sedimented until it's completely part of the logics of the field. And it depends on the distributed agency of the actors that make up this organizational field. There are certain change dynamics. Here also been very strongly on Fünfschilling. This picture you might know, it's a little bit adapted. In order to capture practice, you would have a practice arrangement bundle at the core. That's the most institutionalized part of the practice, and then you have elements outside that are connected or not even yet connected. They are less institutionalized, and you have the endogenous agency, the endogenous change process driven by the field actors that actively institutionalize things or deinstitutionalize things. It's number 1 and 2. These processes, they do that in a situation where there's also exogenous forces on the field that are triggered by shocks like COVID, for example, or landscape pressures like aging societies. And in real life, these things are not happening distinct from each other, but they happen in different extents at the same time and can reinforce each other. When they reinforce each other, that's normally the most dynamic processes. Also, if you have a healthcare crisis, then a push for e-health, for example, might have a higher legitimacy or high acceptance by practitioners than you have in a normal situation. So this is my conceptual framework, my understanding of these change processes so far. The methodological approach is rather simple. I was guided by 2 rationales. The one is really the regional level is most important. You want to understand how these things happen in a localized system, how practitioners deal with the specifics of the place. And the other one is chronic diseases are more likely to trigger transformative change. It's a comparative qualitative case study approach, building on 2 sets of cases. One were experiments that I was part of, where we had in a European project stage-gated co-creation processes where we identified needs in regional healthcare systems, identified solutions, and went through a co-creation process to develop and test these solutions. And in the context to better understand regional healthcare systems, I also did innovation biographies to study what was going on in these regions anyway. And I have a total of 9 innovation biographies that were my other cases. In total, I have more than 50 interviews and all this process documentation, project reports, secondary literature about all these cases. And the analysis was a deductive coding approach followed by this conceptual framework of mine. And with that, I come to the empirical results. First paper is called Open and Responsible. Ingeborg is one of the co-authors of this. This builds on these Jerry's experiments. We had these co-creation processes that are briefly introduced already in Cyprus and in Örebro. They are contrasting a social and technological innovation because these regional ecosystems have this different foci, and it traces how actors implement these novel practice elements through this stage-gated co-creation process. And the picture that you see is depicting these bundles, these healthcare practice bundles with activities, understandings, and materiality. And on the right, you see the idea is new elements are introduced into these practices, new links are built, and some elements are probably not linked anymore than in the future. This thinking and the picture is really linked or really inspired by the normal ways of practice depicted by Elizabeth Schottman. The main point was this paper is that these actors co-create together feasible practice bundles. And what we see, practice innovation really requires a systemic reconfiguration. Healthcare service innovations involve simultaneously technological, organizational, and institutional change. These things need to co-evolve, makes it highly complex because changes in one element, for example, the implementation of a new technology, requires adjustment in other aspects like workflows, norms, infrastructures. And what we saw in this paper is that we can really use a sort of practice theory to illustrate these dynamics. And one consequence out of this is that feasibility is an emergent property of the practice bundle as such. It's not a technology that you introduce that is feasible. You need to make it feasible in enacting this practice. People must be able to work with it. So that activities, understandings, and materialities align in use. So they're called feasibilities and alignment in use. And it's not the property of a single element. Feasibility emerges through the interactions in complex systems. It unfolds in a system where you have a professional self-organization among multiple actors. They are not always aligned, they have different interests, they have different competences and preferences on how the system should develop. And co-creation can enable building feasibility by translating solutions into workable practices. The RI approach that we used was particularly useful for that, in bringing all these people in the same room and openly discuss what is actually needed, what changes are accepted, where do people want to go. But what we also saw, feasibility alone is not sufficient. Feasible pilots fail. There is another stage needed, and that's what I call building legitimacy, to generate evidence and institutionalize the innovations with all the elements within the healthcare system. And that's where the second paper comes in. It's called Bits or Bricks, Legitimizing Transformation. Here I depart a little bit from this traditional social practice theory understanding and say, okay, the activities of healthcare professionals, the activities, understandings, and the materialities they use are shaped by logics, by institutional logics, by organizational logics, by technological logics, and institutional logics. They are introduced at a kind of a meso level to understand how these practices are evolving. Again, I'm contrasting two case studies on diabetes. One is a mHealth telemedicine solution, and the other one is a specialist care center, namely the Pro Empower project and the Wienerberg Diabetes Center in Vienna. And yeah, the picture here is depicting this implementation of new concepts. You have an emergence on the outside, the fringes of the regime. Some new concepts arise. They are then being implemented by creating links and kind of connecting it to existing practices. And then at the end, you have a reconfiguration where new concepts become central, other ones are being pushed out, eventually discontinued. I specifically also said the ending of concepts is one of sign of reconfiguration. The findings from these papers, yeah, legitimacy is really distinct from feasibility. Feasibility arises when the activities, materialities, and understandings are successfully aligned in local routines. But the legitimacy requires field-level recognition of organizational, technological, and institutional concepts as appropriate, credible, and fundable. So you need to get new logics into funding schemes, into laws, into guidelines, and clinical guidelines. Legitimacy is a process of institutionalization in the field, the sedimentation of concepts in the formal and informal structures of the field. And professional identity is a huge legitimacy barrier, especially for things that are more transformative. Professional skepticism or rejection can really stall progress. And institutional work happens, in these cases, in protected spaces, the socio-technical niches, and these frail innovation pilots, they really depend on this institutional work. It's these practitioners who keep pushing for something. It's really their agency that keeps things going until it's sedimented in the field logics, when then it becomes an accepted practice that can be replicated by others and travel over a lot of places. And these protected spaces, they provide context for negotiating the relationship between new practice elements and the old routines, and for creating the evidence that is needed for these institutionalization processes. And building on that, the question about agency arose. That's the third paper talking about practice, where I'm dealing with agency and structure. This paper actually has been published already. It's in regional studies. I'm very proud of it. It's again a comparative case study approaching and contrasting two regions, namely Murcia in Spain and Örebro in Sweden. The one is really focused on technology, driven by an ICT class that would very strongly work with the local healthcare system. And the other one in Örebro, there is a network, it's called the Partnership for Social Innovation, where they really have this very social and very talkative, discursive approach to modernizing public services and healthcare, one of the fields that they're working on. It introduces this relational structure practice agency framework and traces the development of these regional networks through 5 innovation projects each. And you see on the framework, it has these 9 elements. The basic idea is that agency is not aiming at changing structures, it's aiming at changing practices. And through the enactment of the practices, the structures are built and maintained. This practice is the driving force for change. You have past configurations of place-dependent organizational institutional structures, and you have reference and competences from practitioners that stem from the past, and then they come into a present situation where they initiate change processes, where they are facing certain system selectivities to search for new practices. But the thing is also shaped by the future, by the imaginaries of a future working world, by the vision, how practice should be enacted. And between these future structures and future agencies and the present, you have an opportunity space. Like there is some room of maneuver where these future practices can lie, depending on how agency and on how the structures are changed by these actors. What did I find in this paper? There's a co-evolution between structure and agency that shapes on the practice level. It's already mentioned that it's a place and path-dependent process that is inherently rooted in the specific spatio-temporal, organizational and institutional context of a region. Historic structures constrain and shape current possibilities for change and influence how actors perceive the future. There's a crucial role of intermediary actors for creating opportunity spaces. intermediary actors in both regions were crucial in changing the system's activities. They open spaces for experimentation that allowed other actors to perceive and act about new challenges, new opportunities, new possibilities, and they are centrally orchestrating networks. They bring together these actors that are interested in changes, might they come from the public healthcare system, from the industry, or from the civil society. And there are in both regions we could observe two levels of changes. The first level of change is strategic orientation towards experimental search for future practices that allowed this search process to be initiated by other actors. And the second level change would be then the evolutionary alignment of these practices and these new practice elements to transform existing practices. And that's in accordance with the institutional literature's form of aggregation, because it builds up and gets more and becomes a driving force. How do I contribute and what are my conclusions? Key takeaways: healthcare innovation is a dynamic process of reconfiguring practice arrangement bundles that depends on feasibility through the alignment of practice elements, on establishing legitimacy for the underlying concepts on the system level, field level, and on the agency of practitioners to create and act upon opportunities for change. And innovation is shaped by what I call configurational pluralism, because multiple concepts coexist in every field with varying degrees of institutionalization. This means that besides every existing practice, there are plausible alternative concepts that could be picked up in a practice and change the practice. Any innovation is increasing this plurality because it adds new possibilities for creating new configurations. And these concepts, they are always competing for adoption. People standing behind these concepts who have certain interests, and they are competing for being picked up. Thus, transformative change is a path-dependent co-evolutionary process where practitioners choose and stabilize these concepts and their body structures of the healthcare system. Theoretically, I contribute to this literature on procedural frameworks by integrating the three theoretical pillars: social practice theory, socio-technical transition theory, and institutional theory. I'm addressing the critique that transition studies are overly abstract, while practice theory lacks the power to explain change. I introduce this middle-level vocabulary of concepts as field logics that pattern how practitioners actually structure their work. I introduce feasibility and legitimacy as qualities and analytical categories for practices. And the concept of configurational pluralism can serve as a lens to understand the selection, adoption, and generalization of innovations within the field. And this concept also allows a new praxeological articulation of the multi-level perspective by defining niche regime and landscape as relational practice arrangement bundles. For Shatsky, the whole world is a practice plenum. Everything we do is a practice somehow. And this plenum can be sliced at different points. It can be a very small thing, but it can be a constellation. It could be a sector or field. All the things are then institutionalized different things. So you can say, okay, a niche probably is a slice of this plenum that is either locally or not really institutionalized yet. The regime is the highly institutionalized core of an organizational field. Then while the landscape is the relatively exogenous part of the practice plenum that contains all other practices. For example, in healthcare, you have the healthcare system as the regime, and things like mobility and food are shaping it. They're connected, but they're not really part of the same organizational field. And I also contribute practically. I took the liberty to coin the term transformative stewardship, so to say. Stewardship is a policy function that is well established within the healthcare policy literature. It's this self-organization, self-organized preparation of resources and steering of the system, but that's hardly ever coined in a transformative way. It's more like maintaining the resources and the ability of the sector to serve its functions. And I'm arguing that transformative stewardship should be a goal of the sector in order to modernize its structures and its practices to meet these challenges of the chronic diseases. It needs to treat innovation as configuration building. So it's not the adoption of isolated tools, but the deliberate alignment of technological, organizational, and institutional concepts into feasible working routines. And because it's a co-evolution and this concept transcends organizational boundaries of single organizations, a focus on transdisciplinarity and orchestration and multi-stakeholder systems is required. That's where this transformative stewardship would come in as a governance model that actively steers practice change across 4 levels, namely the strategic, the tactical, the operational, and the reflexive. I took that from transition management. Basically, strategic means you need some kind of included visioning and problem framing for the future working world. The tactical is then the creation of these niches through a pragmatic portfolio design to test alternatives. Operationally is you go through innovation pilots, you co-create with patients and professionals innovation projects to create local visibility. And you do this in a very reflexive way. You should use forms like formative evaluation to translate these pilots into evidence for system-wide legitimacy building. And this should be ideally done in cooperation or by using the power of intermediaries. And you would need to invest in the capacities of these people to operationalize the transformative stewardship function and create dynamic capabilities in order to coordinate across organizational boundaries and communities and enable them to translate needs into transformation agendas that guide the experimental search for future practices. But there might be many other things that we need to discuss now. And with that, I end my presentation. Thank you very much.
Thank you very much.